Good afternoon, everyone, and welcome to today's Hopkins Hour on personalised enriched environments in inpatient rehabilitation wards. And we would like to extend a warm welcome to all Hopkins Centre members, partners, and collaborators who are joining us today. For those of you who don't know me, I'm Michael Norwood, so I'm a research fellow in Programme 2, Enriching Environments at the Hopkins Centre, and lead of the BEEhive lab, which stands for the Brain and Enriched Environment Lab. And I'll be hosting today's online seminar. So before we begin today's proceedings, I just want to acknowledge the traditional owners of the land on which we meet virtually today, and the continuation of cultural, spiritual, and educational practices of Aboriginal and Torres Strait Islander peoples. Want to acknowledge and pay respect the past, present, and future traditional custodians and elders of the Yugamba, Yugarabal, Yugara, Jagera, and Turrbal language regions where much of the work discussed today takes place. And we encourage all attendees to research and connect with the traditional owners of the land on which they live and work. Before we get started, there's a few housekeeping items to address. So we are aware that internet connections will vary in this online environment. So if you experience technical difficulties, please feel free to put a question into the chat via the toolbar at the top of your screen, and one of our events team will do their best to assist you. If needed, you can leave the Teams event platform at any time and return to it without losing your place. You can turn captions on via your Teams meeting settings, clicking on the three dots on your toolbar and then selecting language and speech, and then live captions. Please use the chat function to ask questions at any time throughout the session. However, we will aim to answer these at the end when we have a Q&A. So from the top level Teams navigation bar, you can select chat. This should open a panel to the right-hand side of your screen where you can type your question or discussion item into the typed message box. Like I said, so today's speakers will answer as many questions as possible at the end during the Q&A session with whatever time is left. And any questions we don't have time for, we'll share responses for after the session. So today's sessions, we're going to hear about some of the projects which have looked at enriching and personalising inpatient rehabilitation wards. First, I'll speak very briefly to introduce the BEEhive lab for people not familiar and what we do. We'll move to our presenters, hearing from Cherelle, who will briefly talk about an onboarding tool used by nurses in Gold Coast University Hospital. She's a clinical facilitator and research nurse there. We'll hear from Kaitlyn Spalding, who will talk about a research project which explored if, how, and why patients personalise and modify their room. She'll pass to Susan Jones, who is the clinical lead of the BEEhive lab based at Gold Coast, and she'll talk about a current project, which is an implementation project based on the results from Kaitlyn's presentation. We're then going to move to Logan Hospital, where Michelle Porter is running a project exploring use of VR for connection to culture for cold patients interacting with inpatient psychology. She's woke up this morning feeling sick, so I'm going to step in and present her slides, and then there'll just be a chat I have with Joshua Jacobs, who's been using the VR in this context, and we'll talk about his experience with patients. And then we'll have time for the Q&A. So very, very briefly, the BEEhive lab stands for Brain and Enriched Environment Lab. So it's a research network which tries to look at how the environment can impact recovery, rehabilitation, and experience of rehabilitation after neurotrauma. So it aims to be co-designed with clinicians and people with lived experience, looking at a variety of transdisciplinary networks. We're using technology and looking at sort of the physical environment. So you'll hear about, a lot of the projects, so they cover all these different parts of the BEEhive. We aim to collaborate with various stakeholders, where personalization is really important, and translation. And again, all these things will be part of the talks today. You'll hear about talks on technology, talks on the physical environment, and on recreation. So now I'm going to hand over to Cherelle. who's going to talk to you about this honeycomb tool they use at Gold Coast University Hospital.
Hello, good afternoon, everybody. Just to start off, I just want to focus on the actual beehive dynamics of the honey queen bee in the hive. The queen bee is a central figure and undefined force of the honeybee hive. The queen's colony consists of female worker bees, and worker bees rotate through jobs like nursing, guarding, building comb, and foraging. So essentially, as healthcare professionals, we mirror the same. We care, we nurse, we monitor, and we ensure the patient's safety. So I liked this analogy of the beehive dynamics and providing holistic patient-centered care to our patients in rehab. The honeycomb tool there is other tools out there. However, they do predominantly focus on patients living with dementia. And so it was formulated to develop the honeycomb tool to underpin holistic and patient-centered care during their patient's rehabilitation journey. Like the patients living with dementia tool, the honeycomb tool is structured slightly differently. So they predominantly focus on the past. However, with our patients, we focus on the past, present, and future, enabling clinicians to develop a comprehensive understanding of the individual beyond their diagnosis and impairment. The past basically explores the patient's personal history, their identity, their culture, interests, and meaningful life roles that they have in the community. Present, we focus on the current physical, cognition, emotional, and social and communication needs, strengths, and rehabilitation goals. Future, we try and formulate goals for recovery with our patients, see how they integrate within the community, and restore meaningful partition in daily life. Who gets one? We have currently on neuroscience rehab, we have 3 RAP clinicians we refer them to, which is the recreational activities program. Every patient that's admitted to the unit will undergo this discussion with the honeycomb tool. So as you can see with these domains here, central focus is the patient, so preferred name, and then the domains around it, and the tools just help the layers just understand what the patient may require, what they need, just to help their engagement through rehab process. I'm just going to touch upon a case study. We recently had a patient who was admitted post a left MCA stroke, and they lost the use of their right arm. The patient became increasingly distressed, and daily was having code black escalations due to frustration. As rehab healthcare professionals, we support and provide interventions during their admission. So in this case, our RAP clinicians completed the honeycomb tool and interestingly found that the patient likes to knit. However, the patient was right hand dominant. So what our RAP clinicians formulated was to try and actually teach the patient how to knit one-handed. During the engagement with the patient, the RAP clinician was able to teach the patient how to knit. The patient swiftly changed their perception, and their escalation of code black ceased. So enhancing patient engagement, participation in rehab, reducing anxiety through familiar faces, emotional connection, and meaningful interaction, and especially that's tailored for the patient. So more of a holistic approach. It also supports the patient's communication needs, and also promotes a more individualized intervention. Also, this significantly decreased the patient's risk of using restrictive practices. Restrictive practices, basically we refer them to if a patient requires chemical intervention, which we try to avoid as this can negatively impact the patient. It can cause delirium, which then escalates into other issues and clinical problems for the patient. With the knitting with one hand, I believe that this is such an amazing skill. I know personally I can't knit at all with two able hands. So the patient that could do it with one hand, how amazing. And this intervention was really meaningful to the patient. As I said, it created more engagement, which also then transcribed over into creating neurogenesis and promoting neuroplasticity and ultimately reaching their goals during their rehab journey. This approach basically reflects the foundational principles of holistic and evidence-based person-centered care. Thank you. Now over to Kaitlyn.
Thanks, Cherelle. I'll just share my screen. So today I'm pleased to present this work on behalf of a wonderful clinical and research-based team across the BEEhive, Gold Coast Uni Hospital, Logan Hospital, Hopkins and Griffith University. And this study specifically was funded by a Hopkins seed grant and explored if, how and why patients modify and personalise their rooms in inpatient neurorehab environments. So neurorehabilitation inpatient environments are typically designed to prioritise safety and efficiency, yet little is known about how patients experience and adapt these spaces during recovery. Understanding patient-led personalisation and modification practices is important, as these behaviours may create environments that better support their recovery needs, whilst also providing insight into patient agency and the role of the environment in supporting rehabilitation. So a multi-method design was conducted to explore if, how and why patients personalise or modify their inpatient rooms, and to understand the perceived impacts of this on their patient experience. Quantitative data documented observed room personalisations and modifications. So that's those changes that differed from standard hospital rooms. This tool allowed us to use identified features as prompts in subsequent semi-structured interviews, encouraging participants to elaborate on these changes as well as the motivations behind them. Descriptive statistics and a framework approach to thematic analysis was then conducted. In total, we had 31 inpatients who met inclusion criteria, were recruited across 2 neurorehabilitation units. Of these participants, 58.1% were male with an average age of 70.9. The most frequently reported diagnosis was an acquired brain injury, followed by a spinal cord injury. So the most frequently observed items included electronic devices such as laptops and phones. Then there was non-hospital food, drink and utensils. So utensils brought in from home or that were personalised for that individual, and personal clothing and footwear. Here on the slide are 2 images that are just some examples of patients' personalised spaces. The majority of patients were not told that they could bring in personal effects and how to modify their space from the outset. And when they did have things brought in, they reported that they relied on significant others to do so, with one person saying that it was like being drip-fed their effects. But this reliance also then led patients to feel burdensome on their support systems. 3 overarching themes were identified through these interviews. The first, contextual constraints, patient experiences in the hospital environment. And this really spoke to how patients often experienced a loss of agency in this care environment, social isolation, as well as room design challenges. So for example, many felt that PowerPoints were placed too far away so that they actually relied on others to even give them their belongings, even if they were on site with them. The second, patient-led modifications, how and why patients personalise their space. So this theme showed that patients chose to modify and personalise their rooms to stay connected to people, places and their self, and to adapt and engage in functional activities. So, for example, patients position their chairs closer to the door to engage in conversation, social kind of conversation with passers-by. They also use devices from home to stay connected to financial management responsibilities, bills, etc., outside of hospital. Most participants held favourable attitudes to this personalisation, but others just saw hospitals simply as a place to get better and to just go home. The final theme looked at impacts of personalisation, so emotional, functional, and social outcomes. This spoke to how personalisation supported connection to others. It reinforced their identity, it improved emotional well-being, and contributed to that sense of comfort and, most importantly, control when situated within a constricted, institutionalised kind of setting. So in summary, patient-led personalisation and modification is more than just a decorative gesture. It's an adaptive strategy with which patients reclaim and assert their agency and more importantly, identity within a highly structured, often impersonal environment of a rehab ward. So the immediate impact of this study is that flyers are going to be made to give to patients and their families on the benefits of personalisation and modification. And Sue's going to talk more about those ongoing implementation studies next. Thank you very much. I'll hand over now to Sue.
Hello, my name's Sue. I'm one of the nurses at Neuro Rehab at Gold Coast University Hospital. I'd like to just point out that while rehab is very multidisciplinary, interdisciplinary, as far as looking at every aspect of a patient's need, what has been highlighted, especially for me and the other team members with the BEEhive, is that while we look after the patient's needs entirely with all our different disciplines, we've actually forgotten to use the environment that can have a major impact on our patients and their integration in the rehabilitation journey. Next slide, please. So when we look at the patient and personalisation, I'd just like to state that on our unit, we were lucky enough, Cherelle was lucky enough to get some funding from First Nations where we did a mural of the story of our unit and of the BEEhive in the dining room. And that sparked some interest. So instead of the patients just going to the dining room and busy eating their meals and then leaving, it actually encouraged socialisation skills, which is a major part of rehabilitation process, especially when someone's learning to walk and talk again in social settings. And from there, the BEEhive team put in some grants and everything to try and get some funding to engage the environment more. And when you look at the previous research that Kaitlyn has just described, there was statements from patients that says this is a lonely room, and after a while you disconnect from life because you've got 4 white walls and it's depressing to sit there all day. So what we're trying to do is to reduce patient psychological distress, because that's one aspect that is actually huge in the rehabilitation environment. And I think if we address the psychological distress, we can enhance the rehabilitation environment so that we can engage the patients more and they can get more out of it. The BEEhive, or 2 prior studies for the BEEhive, allowed us to put a virtual nature trial on the ward, which had a really good success, and research asking patients if and how they would like to personalise their rooms. If you look at this, we looked at nature because one of the previous research ones brought nature in through VR and it had such a good effect. So when you look at nature and bring it into a hospital, of course you can't bring, you know, soil and everything like that because of infection control processes, but what we can bring in is we can engage the environment in many different ways, whether it be a mural on the wall, whether it be photo frames on a wall where patients have their own family input into it. It could be simple things of patients bringing in photos from home, patients bringing in their own blanket, which can be laundered so that we can meet all the requirements in the clinical place. Because while we use the environment to actually personalise and to bring the patient forward, we still have to be compliant with the stringent guidelines that governs our practice for safe patient care. If you have a look, I'll just go back to the BEEhive and honeycomb that Cherelle was talking about. It gives, for such a simplistic tool, it actually gives the RAP clinicians the chance to use the environment in many, many different ways on a weekly and a daily basis, because they get all the questions from all the patients about putting what the patients want or what the patients like or don't like or what they're interested in or what they're not interested in. It allows the RAP clinicians to develop activities, whether it be personal one-on-one activities, whether it's group activities, to actually engage as many patients as we can on a daily basis. And that is outside of the prescribed gym hours. And it can be simple things like, of a weekend, we have a barbecue where the patients who are on a full diet, of course, they go and they cut their own tomatoes, they cut their own onions, they help cook their sausages, they sit down and socialise in an outdoor setting. So it sort of normalises the patient's journey in a social context to support their new level of function. Next slide, please. So the aims for the BEEhive, and that is to co-create two cost-effective, sustainable environmental enrichment interventions for patients' rooms in neuro rehab. So in that respect, we're in the process of looking at 3 murals in 3 single rooms as a trial to see how it works. And that will be, the murals will be designed with input from patients and clinicians to get the most effective mural for the room. We're also getting some individual photo frames that will go in rooms as well, where families and patients will have a login for each account, which is free. They can download any pictures and everything they want, and the patient can see them on a rotating screen at bedside. And when the patient leaves, that account goes with them and they can maintain it at home if they would like. We also evaluate whether the interventions, such as these 2 that we're implementing at the moment, does reduce the psychological stress, does engage participation, especially not just for the patient, but their families as well, because unfortunately some patients get very lonely on our ward, and their family, because their lives are very busy outside the hospital ward, they don't have as much input from their family sometimes, which can again add burden. But by the photo frames, the families can have input as well on a daily basis. And also we can produce evidence needed that if it is successful by using these environmental strategies, that it's improvement for patients' psychological distress, and by doing that we will decrease any use of medication like mood stabilizers and things like that, which can have a negative impact on the patients as well. If you go to the next slide, please. You'll see, sorry, I've just lost you. There we go. I'm back. Sorry about that. You'll see the picture that you're seeing on screen is pretty much a standard hospital room. Some patients are very lucky to get a window. If you're in a 2-bed bay, you can be unlucky and not have the window side. And what we envisage to do, and the next screen, please, you will see our virtual reality mock-ups. But that is what could be a room that a patient can look at. And again, they're only AI examples of how nice a room can be. Next screen, please. And just to let you know, we do have quite a big team with both academics and clinicians to work on this, and it works very well when we collaborate with research, and it helps the translation from research into the cold front, and that is one of the main aims of where the BEEhive first came from, because we all know there is such wonderful research out there that's proven that it's beneficial for patient care, but unfortunately it doesn't translate into the clinical space, and that's what we are trying to do as the BEEhive, is to do the here and now, have it research-based, evidence-based with positive patient outcomes, and have it immediate and sustainable. Thank you. I'll give you back to Mike.
Thank you, Sue. I'll just share my screen and my next slides. Okay. Yes, so thanks, Sue. And thank you, Sue, who is presenting whilst on holiday, just on her little laptop. So I appreciate that. She can enjoy this for a holiday after this. It occurs to me that another theme for this Hopkins Hour could have been connection. Could have been connection on past, present, and future, on places, people, and self. Cherelle talking about the honeycomb tool, looking at past, present, and future. Connection was a major theme in what Kaitlyn spoke about, and there's murals and digital photo frames are sort of aiming to connect to sort of past, sort of pre-injury selves, and the present, and then sort of the places and people that are waiting outside the hospital. But we didn't call it connection. So I'll be presenting the next slide on behalf of Michelle. As I mentioned, she was unwell this morning. And it builds into this sort of theme of personalized enriched environments, moving into virtual reality environments, but it's also, works on that theme of connection, which is going in through each of these talks. So the project is using virtual reality to connect to culture, and aiming to improve psychological functioning during hospital admissions. So I do work on this project, so I'm familiar with it. Although I did only see the slides this morning, so I might not be able to present with as much pizzazz as Michelle would have, but I'll try and do the project justice where I can. So the background is, it started with a BEEhive demonstration at Logan Hospital with the psychologist. Chelsea Marsh and myself presented on VR and some of the ways it was being used in the hospital and some of the ways we were using it at Gold Coast. And it went from there, and we sort of used that to get a load of project ideas, and they had a lot. And so I don't know what she was going to say about that presentation, but let's assume she was going to say it was great. But from there, they had this idea of connection to culture using VR with the cold patients. They got a couple of grants, a multicultural grant, and then a PA Research Foundation grant to conduct the research. So the Logan Brothers area has a large multicultural population. Over 20% of households speak a primary language other than English. VR experiences that simulate patients' native environments can help reduce stress and anxiety. They provide a sense of familiarity and comfort. It allows patients to virtually connect with their culture, to promote this sense of belonging and belonging to something outside of that hospital room and ward. So this could contribute to coping and adjustment during lengthy or challenging hospital admissions. It can improve mood engagement with treatment, and hopefully reduce the occurrence of discharge against medical advice. There's different ways we can look at connecting the culture through virtual reality, and we'll talk a bit about them later on. But it can simulate cultural celebrations, maintain familial bonds, provide emotional support during some challenging times, and it offers Cowl patients opportunities to engage with VR technology. Connected cultures can be empowering to help people take an active role in their healthcare journey, provide a sense of agency and control. So we hope that this research and this technology will help facilitate improvements to psychological well-being, foster cultural understanding, and contribute to better health outcomes. So that was essentially largely the aim of this project: facilitate a deeper connection for Cowl consumers to their cultural identities while in the inpatient space, using culturally specific VR experiences as part of psychology sessions, and then eventually looking at the impact on experience and overall well-being. Just move the slides forward. Okay. So there was 2 phases to the project. We've completed phase 1, where we spoke with Cowl community members. We had small focus groups to talk about, to get a little VR experience and get feedback on the use of it and sort of how it could work as a cultural inclusion part of psychology sessions. And then phase 2 will be sort of testing it with people in inpatient psychology sessions at Logan Hospital. So phase 1 we've finished. We had 5 workshops of different cultural groupings from Middle Eastern background, Pacific Islands, European, Southeast Asian, and Central and Eastern Africa background. We had interpreters and HLO involvement. Not going to take a guess at what HLO stands for. I did know at one point, but this is a Michelle thing. And the HEAT team assisted in the recruitment, and they supported through the sessions. So essentially, we gave them a VR experience. We had a couple of different videos going on, a couple of headsets, some nature-based, some sort of maybe some buildings or built settings. And there was we talked about how we could tailor them to the groups. So some had animals, nature, some had marketplaces, historical sites. And you can just use, YouTube has a 360 video setting you can use to find these videos. And we had some prompting questions, but it was mostly an open discussion, looking for feedback about how they felt this tool could be used within the inpatient space, how it would impact their stay, and even sort of how they would, the initial conversation about VR, how they would prefer this conversation to be brought up, any additional support they would like, or places they would like to visit. So there's some findings reported in each group. There are definitely similarities, and then some differences. So similarities, support from HLOs comes up a lot. So this was, they talked about the getting community input and community sort of backing for something new like this, for patients coming into the hospital, sort of already having an awareness that it was something their communities supported. Family and familiar places was common across all of them, and control and choice was common. So we'll talk a bit more about that in a second, about the themes that came out. Personally, so taking part in these workshops was brilliant, to be honest. It was really sort of a satisfying sort of fill your cup type stuff, hearing people's just enthusiasm for the idea, the connection to culture idea, that this was what people were thinking about for patients from their communities. People were really enthusiastic about that. And then hearing people's reactions to seeing the example of VR videos was really great. People you hear them expressing awe and joy when an elephant walks past all of a sudden, the level of immersion we have. Even funny things, people walking through Italy and suddenly saying, "Oh, gelato," was quite nice. So, and the workshops were great, really nice to be involved in. The common themes that came through, and a big shout out to Chelsea Marsh, who has helped sort of lead this with Michelle and help build Michelle's experience doing this type of analysis. A lot about came through on sort of why it would be good, I suppose. Their hospital experience, they feel isolated, they miss their family. The environment is generally quite distressing, things that comes up in some of these other projects we've discussed. That the VR could be a good distraction, help them escape the hospital, help improve mood. Connection, I mean, and this is why I said connection could have been the other sort of name for this Hopkins Hour. It came up a lot, obviously cultural connection, that's what we're exploring. But things like identity come through, and that's come through in all the other projects as well. This connecting to self, remembering who they were before they came in an environment which kind of disconnects them from who they are. Personalization was huge. I mean, there was definitely things that came through on what type of content people would like to see, but for sure, everyone spoke about wanting to maybe have a conversation with the psychologist to understand what exactly they wanted to do, what was going to be good for them in that moment. I realize I haven't clicked the slides forward. Here we are. Agency, participation, and you might remember agency coming up in Kaitlyn's project. It's really important, and this provides some sort of, especially if people can personalize it, provides some agency in what happens in those sessions. They can choose where they go. They're connecting to that sense of belonging, which makes them feel more like themselves. Learning was important to some of the groups, so that came through as especially people talking about wanting they'd watch some VR videos, which was educating them on sort of Maori culture. So that was helping them reconnect to their culture through learning about it. Was a really interesting one. And then cultural safety and respect was the last one, and that goes back to again the inclusion of community members and prominent community members and getting that community backing. This also being a way to create a sort of awareness and cultural safety and respect with the clinician as they sort of run these sessions. So there's a few quotes we can share which are quite nice. I mean, so connection is something we've found come up again as different projects. People, place, self, and here are they're in cultures. So current environments being quite isolating, providing no real way of connecting to any of these things, which can obviously be very problematic and have serious consequences on psychosocial and emotional outcomes. So people talking about reducing stress, just having those visuals. People feeling like it's very, very immersive, this type of approach, this virtual reality, so they can help them feel very safe and disconnecting from the reality of being in that hospital room. A way of creating that sense of getting home or seeing family. The whole purpose of this is to love yourself and to love life. I mean, that's a really nice quote. Giving people sort of, they talk, light at the end of the tunnel, talking about hope, talking about connecting to themselves, and feeling empowered. So yeah, there was lots of enthusiasm for the whole approach. So phase 2 will be creating a sort of suite of cultural videos for demonstration to use in the inpatient space. We'll talk about how the conversations that clinicians can have to get that personalization and get people's input. So what videos they do want to see. But there's definitely places that came up for certain groups. So some places came up Mecca or markets, or for some parts of natural environments were more important. In the East and Central African groups, sort of wildlife and villages were important. So we can create a little suite of videos we can use, but while also building that personalization. And the next phase will be running this in the sessions and collecting some data to look at sort of outcomes and experience of using these within an actual session. Okay, so that was me on behalf of Michelle. Again, please put any questions you might have on any of these projects in the chat. The next thing we're going to do, I'm going to stop sharing this screen. I'm going to introduce Joshua Jacobs. So I'll let Josh introduce himself, but essentially Josh has been using the virtual reality with his patients, with looking at cultural connection and exposure to natural environments. First, I will stop sharing so we can see Josh, and we'll have a chat with him. I'll let him introduce himself, and he can talk about sort of his actual experience of using this.
Thanks, Mike. Hi, everyone. Hoping you can hear this.
I can hear you, yeah.
Perfect. My name is Josh. I've been an inpatient psychologist at Logan Hospital for the last 5 years. My main clinical focus has been sort of helping patients in the medical or surgical sort of setting who are going through psychological issues while in hospital for medical reasons, or in the rehabilitation space. And so my first introduction to VR was actually through you, Mike. I'm not sure if you remember, but when you were doing a project in our rehab space here with Dr. Leslie Gunn, and I guess that was my first kind of introduction to it. I just happened to sort of be around when Michelle and a couple of other staff members were sort of starting this project and had just bought the equipment for VR. And it was just kind of sitting in the office, and I just happened to play around with it, just kind of exploring it and helping them to set it up. And in that process, I think we were starting to think about, hey, how could we use this for the patients that we see in the inpatient wards or in the rehab space? And that kind of kick-started then a more serious discussion with the rest of the team to see how could we use this new technology to kind of aid our current psychological interventions, particularly when it came to things like relaxation, motivation, emotional regulation, adjusting to maybe long hospital stays, chronic pain, and even at its, at a basic level, distraction as well.
Thanks, Josh. So when did you start, having sort of explored all that, when did you start using it sort of with patients in the hospital, and what was sort of the first reason you decided, or, that you used it for what purpose in that first instance?
I think it just happened to be happenstance where I was with a patient and he happened to mention he had issues with mobility, and he happened to mention that his main way of coping with any psychological distress would be to walk and to go for walks, which he obviously couldn't do. And it was just kind of in that moment, kind of going, hey, we've got something that we could use to sort of help to visualize or help you immerse yourself in the act of walking despite not being able to do it. And so he consented to it, and we kind of just brought up the headset. He wanted to do like a walking tour of China. And so we kind of popped it on, and that was, I guess, one of the first few experiences of seeing firsthand how much it meant to someone, and to be able to, for him to access a coping mechanism when he actually couldn't physically walk, I think was a bit eye-opening and sort of, helped us see some of the possibilities that we could sort of use it for moving forward.
Yeah, that's great. Was he had a background from China? Was he sort of doing that connection to culture, or just sort of exploring on holiday?
No. So he was Caucasian, and I think it was more a place that he always wanted to go. And sort of just, it was exploration, a little bit of escape thrown in there as well, if you will. I think we do have other cases where there was the element of connection to culture. There was a long stay ICU patient who was critically ill, had lots of difficulties with communication. She was originally from Fiji, and I think in her work with the psychologist on the ward, it was identified that she really missed home and spending time at home. So we then used the VR headsets to show her 360 videos of Fiji, which had a tremendous sort of impact on her mood as well.
Yeah, amazing. How sort of moving forward, how do you see VR being used, I guess with your own use of it, but in general, have you noticed any other sort of opportunities or things that you think it might be useful for?
I think before I go into that, I think obviously I've talked about the patient aspect. There's also been a bit about how we've used VR with staff. So I think we've with some of the nursing staff who sort of work with cognitively impaired patients, we've been able to sort of give them a glimpse into, I guess, the perspectives that their patients may be going through. So, showing them videos of people experiencing visual and auditory hallucinations, or videos of people experiencing like overstimulation, and kind of we, show them these videos and then have a chat with them about their experiences, and with the main aim to kind of help to build empathy for these patients and also to bridge some relationships. So that's been a really good sort of experience that we've managed to walk staff through, and the reports has been that it's really helpful. So I think, from both the patient side and the staff side, there's a lot of opportunity going forward, to utilize VR. We have found that there's quite a readiness and a willingness to engage with it. I think it's a novel tool, but even then, I think many people have heard about it, even if they haven't experienced it. And it just helps to open a lot of access. I do think there are a few barriers that we obviously have to address. I think you and me, Mike, have worked through the biggest one being just a connection to a stable internet.
Yes, it's ridiculous.
And Wi-Fi. We started off using, free Wi-Fi and then onto phone hotspots. And I think Mike finally helped me hook up to Eduroam in the hospital, and that's been great.
Yeah, it wasn't easy, was it?
Because it's hard to be immersive when the video keeps stopping and you have a buffering wheel in the middle. So I think it has been tricky to learn how to use the VR. There's a bit of a learning curve for clinicians, I think. Just when you're having to then navigate it bedside with a patient and set up things like the virtual boundaries and things like that. There is a bit of a limited scope at the moment. I've just been using YouTube videos, which are free, but I think I'd love to be able to be in a space where we can create our own fit for purpose content. Even videos showing the Logan Hospital setting or procedures in the Logan Hospital setting, so that people can start to visualize it even before going through it. And I guess seeing it being more integrated into clinical work, I'd love to see that happen.
Yeah, amazing. Yeah, thanks, Josh. Yeah, it's great to hear all the sort of different uses by clinicians, and I think getting that tailor-made content might be sort of the next sort of steps.
Yeah.
There's a question here before we go to the Q&A, because this one's about VR. It says, do you have any learnings from patients who struggle to tolerate wear headsets? Have you experienced any sort of patients not wanting to put it on?
No, not particularly. I can't say I have, but I think we do tend to use it at very short bursts in time, so we don't tend to leave it on for a very long time. I think the max I've ever done it has been less than 5 minutes. I think knowing the tolerance that patients may have for it, sometimes if you leave it on too long, people can get, some people may experience slight dizziness and things like that. I think there are different kinds of headsets out there. Some, depending on their form and their shape, some could be easier for people to wear. We've only ever used the MetaQuest 3, and they're quite bulky, but I know there are sort of smaller devices out there that may be easier to tolerate.
Yeah.
I can't say I've tried them all, though.
Yeah, I mean, we haven't come across people really struggling to want to wear them. And again, you say interesting, you're saying using it for less than 5 minutes, because we found that with the virtual nature, less than 5 minutes was enough for decent outcomes. But Naomi, thank you for the question. I do have we have a partner collaborator who has used it in pediatric oncology with young people. So if you want to get in touch, we can ask her if she's had any of that experience. And Elisa, yeah, interesting talking about using it in palliative care, because there's definitely some research coming out where that's quite a useful place for it, and we have partners who in the States who sort of do they call it tandem VR, where they do experiences with sort of the family members where they sort of can both go and visit a place. All right, so thank you very much, Josh, for sharing that. It's really appreciate that. We might now invite all the sort of speakers, so Cherelle, Kaitlyn, Sue, me and Josh can step in for Michelle, because Josh is involved in the VR cultural. And yeah, again, if anyone's got a question, chuck it in the chat. But maybe for the Q&A, I'll just start with a question for Sue. So I just wanted to go more on the digital photo frames. I was wondering what kind of content you might recommend people send to the digital photo frames, and why would you choose that sort of content?
I think the content to go to the photo frames would have to be individualised. When you look at a person, they might want photos of pets. They might want family photos of grandkids. They might want scenery photos. They might want beach. So I think you'd have to use the honeycomb tool in relation to what that they would like, and then pull the family in as well. Because if you kept putting family photos down, that might actually have an adverse effect on the patient. But if you bring the patient into the centre and say, hey, what would you like to look at? What and that still might change depending on where they are in their journey. They might not want to look at family, when they're doing it tough in the gym. They might want to look at their dog, or their cat. They might want to look at just a sky with clouds. I think it changes, and I think when we use the photo frames, we need to take that into account as well, and not just have one script for the whole journey.
Thank you. Yeah. As a non-dog owner, I was amazed at how often people wanted to see their dogs in Kaitlyn's project. It came up quite a lot. Dog owners are not as surprised when I speak to them. Thank you. Okay. Kaitlyn, just going on to your project, what would be sort of, based on all the findings you have, what would be your key suggestions for healthcare facilities, or even for practical steps for patients to sort of improve? How would you improve patient outcomes based on that research? Or, how would you speak to healthcare facilities and families and other clinicians to do that?
Yeah, I guess if we think specifically, if we think about patients, it would be giving permission to say that this space is yours, and within obviously the constraints of safety and quality standards. So having a chat with your healthcare professionals around that, but bring things in, things that you can move around in, set up the room in the way that works for you. And because it isn't trivial, it can help with your mood, it can help you stay connected to everyone, and to support those daily routines and habits that support, your recovery, physically, emotionally, psychologically. Family members continuing to bring in those things, that small personal touches make a difference, helping them to personalize that space, and as people talked about, photos, familiar objects, comfortable clothing and devices that they can kind of use, even not just bringing things in, but helping them to set up the room, moving the chair in a way that they can see out of the door if they want to, or if they can have a better view out their window if they're fortunate enough to have access to that, or setting it up so that the things are in place, the PowerPoints are all kind of connected in that for them. So working alongside to enable kind of that really has ongoing impacts for your loved ones in that space. And then clinicians is not forgetting the impact that personalization and modification can have, keeping patients at the center of their care, and encouraging them to do this, giving them that permission, utilizing whether that be through conversations or through maybe developed resources or in orientation packs, or in collaborative conversations when meeting with specialist clinicians like our RAP kind of nurses when coming on board, and giving them that specific detail of what they can and cannot kind of bring in, what isn't appropriate from a safety, hygiene kind of perspective, but what is welcome, what is practical and appropriate. So really having in the back of your mind that it's not it's not clutter, it's coping, and it's connection for people, and it's really important to enable them to do that, and for them to reclaim that kind of agency in this space.
Yeah, thanks. I like that. It's not clutter, it's coping. It's a nice little catchphrase. And you can see how like everything's talking about personalization and connection, and how the honeycomb tool that Cherelle introduced that they use at Goggers Hospital sort of helps, you know, integrate that and promote those conversations. Okay, so I think that's probably all we've really got time for. I will share my screen and just sort of finish up. So yeah, thank you again to all the speakers today. I think that the sort of the themes of connection and personalization, for it's probably no surprise to the clinicians in the crowd, but thinking about how that relates to the environment and focusing a bit more on the environment, hopefully it's something that people can go away and talk about. So yeah, thank you obviously to our funders who support all this work at NISQ and Metro South Health. It's been a really pleasure to have you all join us. We hope you found it informative. And hopefully there's something you can take away and use or explore further. If you'd like to get in touch with any presenters, then please do. Please contact myself or the Hopkins Centre with any questions. So thank you again, and hope you have a really great week.